we presented at the European Academy of Neurology meeting a pooled analysis of 2,443 patients to evaluate cardiovascular and cerebrovascular safety of Erenumab over time. The evaluation included 4 large studies. First, a trial of Erenumab for episodic migraine, which included a 12-week double-blind treatment phase, and then 5 years of open-label treatment. So this is the longest study that has ever been done with a monoclonal antibody for one of the anti-CGRP monoclonal antibodies. Trial 2 was a randomized controlled trial of Erenumab for episodic migraine with a 6-month double-blind treatment phase and then a 7-month open-label treatment phase. Trial 3 was also for episodic migraine, and it was a 3-month double-blind randomized controlled trial followed by a 28-week open-label treatment phase. And Trial 4 was the regulatory trial of Erenumab for chronic migraine with a 3-month double-blind treatment phase and a 1-year open-label treatment phase. And we also evaluated Erenumab in these evaluations for those. We evaluated the migraine patients who were exposed to Erenumab with those who had no history of aura and those who had a history of aura because of concern that aura might generate a greater risk for cerebrovascular or cardiovascular safety. And we evaluated that in both the double-blind treatment phase patients and the open-label treatment phase. So this was quite an extensive evaluation, and a variety of ischemic and central nervous system and heart disease outcomes were included in the analysis. The first part of this was to evaluate the incident rates of adverse events at baseline in the patients with and without aura. And there was a slight increase across all of the patients with a history of aura for most of the risk factors. Diabetes was slightly higher in the aura patients, hypertension slightly higher in the aura patients, hyperlipidemia was slightly higher in the aura patients, a higher body mass index was present in the aura patients. Current cigarette use was actually higher in the aura patients. When one looked at patients with multiple vascular risk factors, that is at least 2 risk factors, again, that group was higher in the aura patients. It did look like going into this data evaluation that the aura patients were at greater risk. They appeared to have a greater number of risk factors. The total number of patients was not that far apart. We had 1,303 patients with no history of aura and 1,140 patients with a history of aura. Then we evaluated the rates of adverse events during the double-blind treatment phase of the episodic migraine trials and the chronic migraine trial, evaluating for serious adverse events, fatal adverse events, cardiovascular and cerebrovascular disorder adverse events, central venous thrombosis, hypertension-related adverse events, and then hypertension alone and diastolic hypertension alone. And we found that essentially the patients with and without aura had adverse events at the same rate as placebo. And it didn't matter whether the patients had a history of aura or no history of aura. They were essentially equivalent. When one included any adverse event, then there was a rate of adverse events that was pretty much the same between aura, non-aura, and placebo, and then all of the other adverse events that I described were pretty much the same as placebo. We then evaluated the exposure-adjusted incidence rates of adverse events in the open-label treatment phase in the patients with and without aura. And remember, this went out as long as 5 years. And once again, very interestingly, the patients with a history of aura and the patients without a history of aura were essentially identical. There was no increased incidence of adverse events in the patients who had aura, despite having had a few more risk factors at baseline. And we looked pretty extensively. So we evaluated cardiovascular and cerebrovascular disorder adverse events in total, separated out cerebrovascular disorders, cerebral venous thrombosis, transient ischemic attacks, myocardial ischemia, Raynaud's, angina, atherosclerotic coronary artery disease, blood MB increase, hypertension-related adverse events that included hypertension, diastolic hypertension, and hypertensive heart disease. In not one of these did it look like the aura conferred any additional risk, and the Erenumab rates of adverse events were extremely low. The only one that even registered slightly was hypertension. So in conclusion, the frequency of cardiovascular and cerebrovascular adverse events with long-term Erenumab treatment was similar in patients with and without aura. And then very importantly, as one looked across time in these patients, there was no increased emergence of adverse events over time. So these were very reassuring data, suggesting, number one, that Erenumab appeared safe and tolerable across time. Number two, that the cardiovascular and cerebrovascular adverse events were extremely low across time. And number three, there was no new emergence of risks over time with Erenumab.